Hello and good morning. My name is Dr. Vajir Rahman and I'm working in the University of Child and Sciences in the Children's Hospital, Lahore. Today, while operating on a child with hiatal hernia, I asked the resident surgeons a few questions. They were a bit confused and shaky while answering those questions. Therefore, I decided to make a small video regarding what are hiatal and the paraesophageal hernias. So before wasting any further time, I think we should begin. So first of all, what is an hiatal hernia? The diagnosis of hiatal hernia was basically made on the postmortem cases. On the postmortem cases, they noticed that there was a small hiatal opening through which some of the abdominal contents were going up into the chest cavity. So as we can also see, one is this vena cava opening through which the inferior vena cava passes through. The other one is this esophageal or the hiatal opening, and the third one is this aortic opening. So the main opening through which the hiatal or the paraesophageal hernias takes place is this one, is this hiatal opening or the esophageal opening through which the contents go upwards towards the thoracic cavity into the chest. So coming towards the type of the hiatal hernia. So first and the foremost important thing is you have to understand that the gastroesophageal junction location, because all these types depend upon the location of the gastroesophageal junction. So in the type 1 or sliding hernia, what happens is this, that the gastroesophageal junction protrudes upwards through the hiatal opening, as you can see in this type. So this is the gastroesophageal junction, and this is the some part of the stomach and lower esophagus, and this protrudes upwards through the hiatal opening. In the type 2, the gastroesophageal junction is right in the abdomen over here, but small part of the stomach rolls up through the hiatal opening and enters into the chest cavity. And in the type 3 open hiatal hernia, we also call it the mixed hiatal hernia. In this, both the gastroesophageal junction and part of the stomach goes up. In some cases, they also report that there is a type 4 hiatal hernia as well. In the type 4 hiatal hernia, what happens is that along with the gastroesophageal junction, some part of the stomach, some small other abdominal contents like small bowel, colon, even spleen or omentum can go upward through the heart opening into the thorax. So this is just an overview of the types of the hiatal hernias. So how does the baby presents with the hiatal hernia? In most of the cases, the baby presents asymptomatically without any symptom, and they are diagnosed on an incidental finding, or maybe the baby presents with some other complaints like respiratory complaints of respiratory distress. And then when we do the investigations, we come to know that the patient has hiatal hernia. Or they can present with gastrointestinal symptoms like GERD or dyspepsia, vomiting, failure to thrive, and GERD is a very common complaint as well. So whenever you get a child who is having a respiratory distress syndrome and having amnesia, anemia, and failure to thrive, and that are not fitting with the clinical scenario, so you should also have a high index of suspicion for gastroesophageal. One of the questions I asked the residents during today's surgery was, what is the most dangerous complication if you leave the hiatal hernia untreated or the paraesophageal hernia untreated? And the answer, I couldn't get it at that time though, but the answer was this, that the volvulus of the stomach occurs during hiatal hernia. The stomach goes upward through the hiatal opening and it can twist around it. It was the reported cases, three reported cases were from Turkey, and they noticed that organoaxial rotation around the greater curvature of the stomach occurs, and that can be a disastrous thing for the patient. Now, coming to diagnostic evaluation, how do you diagnose a case of hiatal hernia? Now, the patient comes to you with all these kind of signs and symptoms, and you think that it might be a hiatal hernia, or it can come with small complaints like upper respiratory tract infections, repeated infections, or something like that. So the first and the foremost thing is a chest X-ray. You go for a chest X-ray, and both the anterior, posterior, and the lateral chest X-rays. Now, what the chest X-ray will help you is one, it can tell you about the Bogdalic or the Morgagni types of hernias if they're any, or it can also tell you about the if there are any other respiratory problems the child is having any cystic lesions in the lungs, like CCAM, CLE, or if the baby is just having a upper respiratory tract or lower respiratory tract infection. So you can all judge it on a chest X-ray. Regarding hiatal hernia, the paraesophageal hernia, there is a strong chance that you might not able to find anything on a simple plain X-rays because it can reduce back spontaneously and you might have a normal chest X-ray if it is done at that time. So what we do to confirm the diagnosis in upper GI contrast studies, what we do is we give the baby a small amount of contrast medium to drink it. The baby drinks it, and with the help of a fluoroscope, we identify the entire tract of the esophagus, the stomach, and then we see the exact location of the stomach, and then we take small pictures of different phases of the contrast medium, and then we can find out the exact location of the gastroesophageal junction and the stomach as well. Another option is a CT scan. If upper GI contrast studies cannot make up with the diagnosis, then we go for a CT scan and to find out the hernias. And moreover, if the diagnosis is still confused, we can go for the CT scan to find out some other anomalies as well. There are some also reported cases in which they have done a fetal MRI as well, and they even diagnosed it on the basis of fetal MRI. Okay, so now these are some of the pictures. If you go back and recall the types of the hernia, so the hiatal hernia, we assume that the most important thing is the gastroesophageal junction, this one. So in the type 1, we said that both, so this is the diaphragm, okay? So this is the diaphragm. And here, this one is the hiatal opening or the esophageal opening. So you can see that the gastroesophageal junction has gone up and some part of the stomach is also protruded upwards. And you can easily make a diagnosis based on this one. Regarding the C that too, we decided when we were studying about the types that the most important thing is the gastroesophageal junction, right? So here you can identify that this is the gastroesophageal junction and it is below, and the stomach has protruded upwards, and this is the diaphragm, and the stomach has protruded upward through the hiatal hernia into the chest cavity, and hence it causes problem in the chest. And in the type 3, that is a mixed type, both the gastroesophageal junction, the stomach, and all these things can protrude upward. This is the diaphragm, and here the gastroesophageal is above the diaphragm, the stomach is above the diaphragm, and in the type 4, we deduce that small bowel or other intra-abdominal components can also go up. So the fluoroscopy and the upper GI contrast study is a very good study, and it doesn't expose the baby to much radiation as well, and you can easily diagnose based on this one. So if you have came so far watching this boring video, so you must be a surgical resident that you have been going through all this. So, so what are the important surgical things, important surgical principles when operating hiatal hernia or paraesophageal? So first of all, there are different incisions. You can go for a midline incision, or you can also go for a transverse. There are four important things when operating on a child of hiatal hernia. The first and the foremost is that when you open up the abdomen, you have to reduce the contents. You have to identify which type of the hernia is this, that you can do it on Parop. And first of all, you have to reduce back the contents, and some of the time there's a sac as well. You have to excise that sac, and then you have to close that crura, and in the end, you have to perform any anti-reflux surgery. Anything can be utilized for that. You can go for any kind of fundoplication to prevent the reflux because it is associated with a lot of reflux disease as well. And the most important thing is while repairing a hiatal hernia, you have to make sure that you use a non-absorbable suture. We can use silk, but it's not used these days, and we have abandoned it. Now we use mostly we use polypropylene or proline in most of the cases. And there are other options. We can go for open repair or laparoscopic repair. And okay, regarding the post-op care, this is really a straightforward surgery, not a very lengthy surgery. Bleeding can be initiated within a short period of time. Now, coming to the complications. The first and the most, although it is not associated with a lot of complications, but one should be really careful while performing, especially in doing a redo surgery, because then a lot of complications can arise. So, recurrence is one of the complications, and if there's a recurrence, We have to put up a mesh. We have to make a trouser leg mesh, and we have to put a pulling type mesh, and we can close it with a mesh. Other important complications per op can be there can be gastric injury, and if that happens, depends on the surgeon's preference. He can even close it in a single layer, or you can close it in a double layer. And then there is esophageal perforation as well. And if that happens, we can even close it. And it is advised that after closing it, we can do a fundoplication over that repair, and both of these complications can be managed quite easily. Other than that, there are other complications like dyspepsia, recurrent pneumonia, pneumothorax, bowel obstruction. All these can be managed accordingly. And if the patient is having dysphagia, so it is advised that we manage the patient for 4 to 6 weeks conservatively with liquids before considering so that's all for today, and I just wanted to make a short video because the lengthy videos usually gets real boring and you don't get the main crux of it. I tried to cover most of the things regarding hiatal paraoesophageal hernia, and if you still have any questions, you can ask me directly or you can write in the comment box, and we will try to answer those questions.